Hello, I'm Chris Morgan. I run the Sleep Medicine Center at Trinity Health over on 245 Cherry, and I also run the neurology residency here. My background is in neurology, but um, I've done practice sleep medicine as kind of my subspecialty for a while now. I came here about 10 years ago or so. I've also been involved in organizations around the state too, but I have particular interest in how the overlap of sleep medicine and neurological disorders. So it's a pleasure to talk to you guys all today. And I hope that you can learn a little bit about sleep, and hopefully if you have any questions, I can stick around for a little bit as well. But Susan asked me to focus on kind of the relationship between myasthenia gravis and sleep apnea. So that's what I'll be talking about today. So I first wanted to talk about the relationship between fatigue and sleepiness in myasthenia because a very high proportion of patients with myasthenia have fatigue and also sleepiness, a pretty high portion as well. And as you probably know, those of you out there that have myasthenia or have interacted with family members with it, sometimes the fatigue can be an indicator that there's muscle weakness going on too. And this is just kind of a diagram of the percentages of fatigue compared to controls, which is obviously much greater than people in the regular population with how much fatigue is going on in myasthenia. And one of the things that can lead to fatigue is sleep disturbances. So there are a lot of things that can cause sleep disturbance. About half of patients with myasthenia report some sort of sleep disturbance. With muscle weakness can contribute to it, and this is what I was talking about—the kind of that peripheral fatigue feeling that can be an indication that things are getting worse with the weakness. About 30% of patients have respiratory muscle weakness, and fatigue can be a sign of this as well. 50 to 20% may require ventilatory support at some point in their life due to the respiratory muscle weakness. Sleep disorders are a big thing, and I'm going to focus on those today. Obviously, sleep apnea being the biggest one. Sometimes there may be difficulty sleeping on the back because of respiratory secretions. Your cough reflex is suppressed a little bit when you sleep, or hypoventilation, so not breathing deeply enough because of the respiratory muscle weakness, or because of excess weight. Um, Immobility can affect sleep disturbances, pain, depression, or anxiety, other mood disorders, or some of the medications that are prescribed, such as pain medications, muscle relaxants, things for anxiety, depression, sleeping pills, may contribute to sleep disturbance during the nighttime. So, what sort of sleep disorders do we think about with neuromuscular disorders or myasthenia gravis? So snoring and sleep apnea is one that I'm going to focus on today, but I was going to run through a couple other quick ones just um, to let you guys know about different sleep disorders that can happen. So hypoventilation, so this is when you don't breathe deeply enough when you sleep, and it can elevate your carbon dioxide levels in the blood, and that can cause you to feel unrefreshed in the morning, headaches in the morning time because of that not breathing deeply enough during the night, and can also be because you don't have the strength to breathe out strongly enough as well. So that's when if you've ever been in the clinic and your doctor has had you blown into the tube to kind of measure how much force you put out, that's called the forced vital capacity that they try to keep track of in the neuromuscular clinics. And nighttime and daytime panic attacks or anxiety could be a sign that you're not breathing well when you sleep at night, if you wake up in a panic or gasping for air. Insomnia is obviously a very large part of what we do in sleep medicine. People having either difficulty falling asleep or staying awake or waking up through the night or waking up too early can all be signs of insomnia, and there can be many, many different causes for that, including sleep apnea. Leg spasms or cramps can bother people through the nighttime. Frequent nighttime urination, um, restless legs. So your legs feeling like you got to kick or move them before you go to bed or in the middle of the night. There was one study that showed restless legs is about twice as likely in myasthenia patients, but there really has been limited data on all sleep disorders in myasthenia. We need more research on it. We only have this one study showing that it's about twice as likely. And interestingly, RLS was the most disturbing health problem for 9% of the RLS positive myasthenia patients. So it definitely can get pretty severe sometimes with myasthenia. Circadian rhythm disorders can be an issue, especially if you're not being very active during the day. You end up laying down, taking naps when you're sitting there, and especially if you're not feeling well. And this can kind of throw off your sleep schedules where you get all irregular schedules. Um, so those are some of the different things to think about with sleep and things that we address, at our sleep clinic as well. So in terms of sleep apnea, because of the effect on the diaphragm and respiratory muscles, including the muscles in the back of the throat, it can increase the risk for sleep apnea. It's about maybe most articles will say 30 to 50% or 40 to 60% prevalence of sleep apnea in myasthenia. There's only been a few different studies looking at the prevalence. So we typically see that it gets worse too in your dream sleep or your REM sleep at nighttime. So that's something that normally when we all go into REM sleep, our muscles in the back of our throat relax, and the whole body actually are paralyzed so that we don't act out our dreams. So with myasthenia, when you already have some additional muscle weakness, that can cause more of an issue. Um, and a lot of times you may see this with more sleep disturbances towards the end of the night. So this is a normal sleep schedule. So normally we get more deep sleep in the beginning of the night and then more REM sleep towards the end of the night here. So the REM cycles come every 90 minutes, every 60 to 90 minutes, and they get longer as you go towards the end of the night. So there's also some people feel that acetylcholine may play a role because, as you may know, part of the issue with myasthenia is the release of acetylcholine to make the muscles move. And this is a core neurotransmitter in REM sleep. So there may be some issue with the muscles moving well in REM sleep because of that intrinsic problem with myasthenia. Sleep apnea can also worsen with increased symptoms of weakness. So people that are more fatigued or weak during the day the sleep apnea might start to worsen as well. There are also some evidence that treatment of sleep apnea may improve myasthenia symptoms. There's been several case reports detailing patients getting better or having much decrease in their exacerbations once sleep apnea was treated. This includes decrease in ventilator dependent exacerbations and paradoxical weakness, so weakness where it kind of comes and goes. And there was one study showing ocular myasthenia that improved with CPAP therapy as well with treating sleep apnea. And in vice versa, treating myasthenia can also improve sleep apnea. There was a study that showed patients that had thymectomy, 6 out of 9 of those patients had significant improvement in their sleep apnea. So if we make the muscles stronger, theoretically, you can keep the airway open better from sleep apnea as well. There's some evidence that myasthenia patients with sleep apnea may have worse cognitive function. Again, there's not a lot of studies on this, but one or two that have shown that. There may also be an increased risk of something called central sleep apnea, which is where the brain doesn't tell the body to breathe properly when you're sleeping at nighttime. So that's different than obstructive sleep apnea where the airway is collapsed. And I'll kind of go over what causes that too. So risk factors for sleep apnea and myasthenia patients include male gender, older age, increased BMI, which is a risk factor for everyone for sleep apnea, but especially in myasthenia because it makes the hypoventilation worse or decreased breathing during the night worse. If you have an abnormal total lung capacity or restrictive lung disease, any diaphragmatic weakness that's resultant from the myasthenia, if your blood gas concentrations or the oxygen and its carbon dioxide are abnormal during the day. If you're on chronic steroid therapy, this can lead to weight gain and worsening of sleep apnea and reorganization of the adipose tissue in the airway when people on chronic steroid therapy. People that have gasping or morning headaches or daytime somnolence or early morning weakness, which is another term for that paradoxical weakness where they feel weak when they first wake up. If that can be an indication that your sleep is not good at nighttime and you're stressing your body out through the night. So then instead of feeling the best in the morning, which mostly how myasthenia patients feel is they feel the best in the morning. If you're feeling worse in the morning, that can be an indication something's going on with your sleep at nighttime. So what is obstructive sleep apnea? So obstructive sleep apnea is where the throat gets blocked off from the air. So it's an anatomical issue where the tongue and the palate come and kind of block the air off. And when this happens at nighttime, the oxygen starts to drop. So your blood oxygen level goes from, this in this particular example, 97 down to 74. This particular patient stopped breathing for 47 seconds and 86 seconds, bringing their oxygen down. So it can have pretty significant implications if that's happening, hundreds of times at nighttime, which most of my patients with sleep apnea, this is happening many, many times per hour. And we usually classify it if at least 5 times per hour this is happening, then you have sleep apnea. Um, More than 15 is moderate, and more than 30 times per hour is severe sleep apnea. So if we don't treat the sleep apnea, what other risks are there to our body besides potentially worsening myasthenia? You have to think of other systemic problems such as worsening high blood pressure, the increased risk for heart attack and stroke, diabetes, heart arrhythmias, particularly atrial fibrillation. There's this large increase in the risk for car accidents. Mood disorders can worsen. Significant issues with memory long term in people that don't have sleep apnea treated. Decreased sex drive or sexual dysfunction with sleep disruption can affect your immune system too when you're not sleeping well, and can worsen things like acid reflux or heartburn. So a lot of implications through the whole body with sleep apnea not being treated. On a day-to-day consequence, which is what we probably most patients come to us, is they're not feeling well, they're feeling tired during the day, they feel like they can't get through their day. People can have decreased work productivity or higher chance of not missing work. I picked this picture because I thought this guy kind of looked like me, but I don't know. Susan, you'll have to tell me if you think so. And then a lot more missed family and social activities, reduced quality of life, problems with learning, memory, substance abuse, lack of awareness or poor judgment, risk-taking behavior, decision-making can be impaired when you're not sleeping well, mood changes, coping with stress and high-pressure situations, increased attentiveness and distractions. So there's a lot of patients out there getting diagnosed with adult onset ADHD, which I think if everyone was treated with further sleep disturbances, there would be a much lesser occurrence of adult onset ADHD. So this is an example of someone who was caught driving, like a cab driver, and you can kind of see they don't sleep very well, and their eyes kind of close here while they're driving. So how do we test for sleep apnea? Well, there's a couple different ways to look at it. So we have home sleep testing devices, which we can send you home to look at your breathing through the nose, and a thing on the chest to measure the effort of your breathing, and then also oximetry on the finger to look at the oxygen drops as well. But sometimes this is not the best for myasthenia patients because we can't actually tell if you have respiratory muscle weakness with this study. You need to have CO2 monitoring for that, which we need to do in the sleep lab. So most of my myasthenia patients, I will request coming in the sleep lab where we have more thorough monitoring of oxygen and CO2 levels. We look at your brain waves to see what stage of sleep you're in. And we can tell a little bit better with the breathing disturbances through the nighttime. So most likely, if you get a sleep study, we usually prefer in lab with the myasthenia patients that I have. So treatments for sleep apnea, I'll kind of go through these for the rest of the presentation, where we have positive airway pressure machines, so things like CPAP or BiPAP machines, oral appliances, surgery, or new devices as well. For hypoventilation, so that when you don't breathe as deeply enough, it requires typically more advanced machines such as BiPAP or more sophisticated ventilators. And there can also be phrenic nerve stimulators. So the phrenic nerve is what supplies the diaphragm to help it breathe for severe diaphragm weakness. And then for respiratory secretions at nighttime, there can be several different medications to help clear those secretions, such as cough assist devices or medications such as glycopyrrolate or guanfacine, or anticholinergics can sometimes be used for excessive salivation or even Botox injections, or if it's very severe tracheostomy, although I think that's very, very last resort for anybody. So when we look at CPAP devices or positive airway pressure devices, what they're doing is they're using air pressure that comes into the back of the throat and keeps the back of the throat open. So when you have this restricted airflow, it does a great job opening it up. Still the best treatment we have for sleep apnea, and technology's gotten a lot better throughout the years. The new machines are very small. I didn't put a size gauge on here, but it's these are much smaller than they used to be. Lots of data on here can tell us everything about what's going on with your usage, can tell us if the breathing is appropriate, and gives us a lot of data that we can adjust and set. And if you're motivated, if I have a motivated patient, 95% of the time I can get them comfortable with CPAP. There's that 5% that just, no matter what I do, they won't do it. If you're not motivated, those are the patients I have more trouble getting compliant with PAP therapy, where they just kind of give up on it after a couple weeks and say they don't want to do it anymore. But we're pretty good at getting people comfortable if you stick with it and use it. So there's a lot of different masks nowadays for the CPAP machines. So much smaller, much easier to use. A lot of them just slip under the nose like this one here, or have small ones that just kind of have one strap going behind the head. So it's a lot less equipment to deal with for many patients. There are still patients that require masks going over the mouth, which we have newer ones that are a little less, not as big on the face. They kind of go under the nose and over the mouth. So there's a lot of different options now, including the hose coming above the head like this, which really helps for movement in the bed. And even some masks with minimal to no straps on them now, and memory foam models, so that it's nice and comfy on your face, doesn't cause those lines and things. So a lot of smart people have thought about this stuff to get patients compliant with their machines. But despite this, there's still nationally about half of people that struggle with CPAP due to mask fitting and leaking, pressure issues, skin irritation. Convenience is a big one for some patients, even though I'm like, you can, personally, I don't think it takes that much to pack it in a bag, but some people just hate packing things in a bag and bringing it anywhere. So I get it. It's a convenience issue. Cleaning, there are those things as well. Some people have severe nasal congestion that they can't use it for. Aesthetics of it. Some people don't like that being in their bed on their face with their partner next to them, or claustrophobia or anxiety issues. But like I said, in a good sleep center that's AASM accredited, typically compliance improves to about 70 to 80% in patients overall. We do things like switching to different machines or different pressures that help people to get more comfortable. And even some new devices out on the market that kind of make it feel more comfortable when you breathe with it, like this new device called the VCOM, where you kind of stick it on the tube, and it's only like $20 and helps tolerance for some patients. So we can get you there. It just sometimes takes some time. But let's say you're one of those, 20% that can't do it. So, or you just don't want to. There's other devices out there. So you may see these online, these anti-snore devices. There's a bunch of these things all over the place. And most of these are mouth guard type devices that will adjust the lower jaw forward. And it does help sleep apnea to some degree, but these are not approved for sleep apnea. They're approved just to help with snoring, and they're also not very durable. These things will usually only last a few months or 6 months, and then you have to buy a new one every time. I've had a couple of patients that they felt it worked, and they would just buy a new one every 6 to 12 months. But otherwise, there's more professionally made ones that I'll go over as well. These breathe right strips, these are more for just like nasal congestion. They don't really help at all with sleep apnea. These chin straps don't really help much either. And these kind of, again, for nasal congestion, opening up the airway. Or if you visited Australia before, or you want to try playing a new instrument, you could do the didgeridoo here for only $25. That'll treat your sleep apnea. So either one, whatever you'd like. There's not a lot of evidence behind this, but there's some evidence that people that play wind instruments have much stronger upper airway muscles and have less incidence of sleep apnea. So that's the basis for what they're marketing this for. It's not really just a didgeridoo, it's any wind instrument that you play would strengthen your upper airway muscles. So take up the trumpet or saxophone or something and may help your sleep apnea. But again, I don't know how with myasthenia, it causes more fatigability. blowing into a trumpet all day long, so I'm not sure about that. So oral appliances are the more professionally made from dentists that we refer to for patients that have more mild to moderate sleep apnea. Um, there's many board certified dentists in Michigan that make these, and we can help you, guide you to a place if you were to ever try something like this. It kind of pulls your lower jaw forward away from the throat to open up the airway with these oral appliances. There's a lot of different kinds of these out there. Ones that are made by 3D printers. Polyurethane, I think, is what they're mostly made of, but this Prosomnus is kind of a popular one right now. So basically, they just have something that's holding that lower jaw forward so it doesn't fall back on the back of the throat while you're sleeping. There's even combination CPAP and oral appliance devices. So these have no strap, and they just fit in the nose, and then something that holds it on with the oral appliance that sits in your mouth too. Other treatments for sleep apnea include positional therapy, where basically you just kind of sleep on your side. So there's some more advanced devices that can help with this nowadays, where they actually have monitoring how much you're on your side and what the snoring level is when you have these devices. And they're pretty good, actually. It's just they're out of pocket costs. Insurance doesn't cover these, so that's my biggest barrier with getting patients to try these positional devices. But for people that have sleep apnea that's worse on their back, which is most sleep apnea is worse on your back, these can be helpful treatment option. There's also these we call nasal EPAP therapies that kind of resist your breathing as you breathe out. These are more for mild sleep apnea, but they can be helpful in the breathing as well. There's other newer therapies. This device called the iNap actually is a suction device. So it goes right under the lips and in front of the teeth, and you kind of bite down on it. And it actually creates a suction in the mouth that pulls the tongue forward away from the throat. Or this is this one actually strengthens your upper airway muscles. You wear it during the daytime. But again, this one's only for mild sleep apnea. This iNap, though, can be for mild to severe sleep apnea. So there are a few other devices. Again, these are out of pocket cost as well. So, but everything costs something. So, and then there's surgical treatments for patients that can't tolerate several of the first line therapies. We can move on to looking at surgery, which, in children we do like removal of the tonsils and palate, but in adults we move more towards upper airway surgeries. The most common ones used to be removing the palate and uvula and advancing the tongue in combination with nasal surgery, but nowadays we have a little bit better success rate with some of the nerve stimulation surgeries, such as hypoglossal nerve stimulation, or the company that does that is Inspire. So these are examples of some of the different surgeries, such as removing the palate off the back of the throat, reorganizing the palate, pulling the tongue forward in a couple different ways to do that. And there's also this jaw advancement surgery, which pulls the whole jaw forward. This one's pretty invasive, but it can have a great success rate. But it's a pretty long recovery time. It takes some time to get better from this one. Then we have hypoglossal nerve stimulation, which uses a remote to turn on a device which actually creates a stimulation up on the hypoglossal nerve to push the tongue forward. I'll show you a little video. It's performed by an ENT surgery, and then we follow you in the sleep center for this. To qualify for this treatment, you have to have moderate to severe sleep apnea. So your number of breathing pauses per hour has to be at least 15, and you have to have no central sleep apnea, or less than a quarter of central sleep apnea. And you have to have tried CPAP before or have not gotten benefit from CPAP in the past. Ideal candidates are non-obese candidates, so people less than 32, but Medicare approves it to people with less than 35 BMI. It's kind of a short video.
Inspire is a treatment option for some sleep apnea patients who cannot use or get consistent benefit from CPAP. It's a small device implanted during an outpatient procedure, and it's all under the control of the patient with the Inspire Sleep Remote. Patients simply turn it on when they go to bed and off when they wake up. Now, let's take a look at how Inspire treats the root causes of sleep apnea. During sleep, the muscles and soft tissues of the throat can relax, block the airway, and cause apnea events. Inspire treats sleep apnea by working inside the body with the patient's natural breathing process. The system is placed under the skin of the neck and chest during an outpatient surgical procedure. The device is turned on by the patient with the sleep remote seen here. After the patient falls asleep, the system syncs with breathing patterns and then delivers mild stimulation to key airway muscles throughout the night to keep the breathing passages open. The back of the airway is now clear and the patient can breathe during sleep.
I keep the remote control right next to my bed. I simply just reach over and turn it on every night and go off to sleep 30 minutes later, and I don't wake up when it starts and activates. And very easy to use. It's like push a button and go to sleep.
So this is one of my patients with Inspire. You can kind of see how this tongue motion works when when the device turns on, the tongue comes forward a little bit like this and kind of comes off the back of the throat. We have over 100 patients with Inspire now in our clinic. Pretty good patient satisfaction. The efficacy is reasonable. It's not as good as CPAP. CPAP, you're getting almost 90 to 100% of your sleep apnea treated. With Inspire, you get probably 60 to 70% real world. So not as effective, but most patients are happy they've done it because it really helps them to feel better. Vast majority of patients, we can get them down into the milder sleep apnea range. Occasionally, we can completely get rid of the sleep apnea. It's probably more like maybe 20% of my patients have had that, but a good chunk of them have been able to get down to a very much lower range and feel better in terms of how much they breathe. In our practice, their average breathing pause number was 36, and we've gotten them down to an 11 on average, and their sleepiness scores have been reduced from 9 to 6. So it can also be combined with other therapies, such as positional therapy or oral appliance, as we talked about. You can do MRIs with the device, worked with CT scans too. Battery lasts 11 years, so works pretty good with that. It's removable, so if you do have complications, they can take it out, although it's pretty rarely done. We only had 2 patients that ever got it removed, and they were for one patient, their sleep apnea resolved, and one, they had infection issues. My concerns with Inspire for myasthenia, though, is that the fatigability of the muscles could be an issue. Now, we don't have any data on this. I actually reached out to my Inspire reps to see if they know anyone that has myasthenia that's on an Inspire device, and they don't, at least right now. But at least nothing's been written in the literature about it yet. This device has been out for 9-10 years now, but only really commercially really popular in the last 3 years or so. But they've had a lot of patients throughout the world on it now. But I haven't heard of anyone with myasthenia on it yet. So my concern is, because as you know, muscles become fatigable. So if you're stimulating your tongue to move throughout the whole night, whether that can cause more issues with like slurred speech or fatigability in the morning time with the mouth, with the tongue muscle, I don't know. So that's something I would have to keep an eye on if we ever did do this in a myasthenia patient. But still potentially could consider it depending on what type of myasthenia you have, especially if it's like ocular myasthenia, it's probably not going to affect the tongue muscle very much. We have other treatments for like central sleep apnea. If you have that type of sleep apnea with specialized type of PAP machines, oxygen can help a lot as well. And there are some medications such as Diamox or acetazolamide that can help. There's also a new device for this that's a phrenic nerve stimulator called the Remedy device, where it continuously stimulates the diaphragm to move when you're sleeping at nighttime, so it keeps you breathing. Again, similar concern to this device is the continuous stimulation through the nighttime going to cause any fatigability in a diaphragm in somebody with generalized myasthenia? I don't know. We don't have any data on that, but could still be something to look at. The nice thing about these devices, they can always be turned off. So if it causes issues, you can always turn them off or take them back out or whatnot. So that's pretty much my presentation on sleep apnea and myasthenia, but I'd be happy to take some questions in the next 15 minutes if you guys have any. Usually there's a lot of questions about sleep, so.
We have some great questions for you. Ready?
Go for it.
If you have any recommendations on how to work with DME companies to help get a proper fit of the mask? My husband has had difficulty finding the best fit. We're in the Detroit area and work with Vincent's. And you don't have to answer like case specific if you don't want, but in general.
Yeah, I mean, it's so variable out there. It really depends on if you get a good therapist. If you can't, if you don't find a good therapist on one, it's okay to try to switch to another DME if you're, sometimes you can't switch DMEs until your machine is paid off. So if he's currently going through the machine paying off, um, it can take some time before, once that's paid off, then you can go to whatever DME you want to, but they usually keep it with the same one. But yeah, it's just kind of getting a respiratory therapist that is good and will work with you a while and give you some different masks to try. Um, go to a sleep center if you're still not getting results with the DME, because every sleep center has their own therapist there that can help and try to sort things out if the DMEs are not getting the job done. We have that issue with patients as well, and sometimes we have techs that'll just take time to work with them if the DMEs are not getting it done.
Okay, great, thank you. Next question. What if you have MG and feel compromised and your sleep center has done an at-home sleep study that does not show any issues, but will not do an in-center sleep study?
I would highly recommend doing an in-center sleep study in myasthenia, just because of that issue with the hypoventilation that I was talking about. Sometimes it's an insurance battle, and maybe that's what you're dealing with. Usually when you tell the insurance there's a neuromuscular disorder, they approve the in-lab studies just fine, in my experience. I haven't had anyone argue with me about that, unless your plan just doesn't cover sleep studies, which I've had a couple patients where they just have an insurance that doesn't cover any in-lab sleep studies. But I mean, you can pay out of pocket for those, but they can be pretty pricey. They're usually a few $1,000s for a sleep study. Um, so I understand your struggle. I would work with your doctor to really push for getting that study in the sleep lab. And most of the time, sleep centers are fine with it, because I mean, that's, it's more helpful for us looking at patients with myasthenia in the sleep lab. So yeah, just if your doctor doesn't know, just tell them, to put that you have a neuromuscular disorder, and usually that insurance will approve that. So
Yeah, and maybe for your doctor's office, just say, I'm having an insurance issue. What do you know as a workaround or that you've tried in the past? But that's part of it then, right? Identifying with your doctor that there's an issue of
right.
doing it in center.
Yep.
Okay, you ready for the next one? Surgery and anesthetics can be a risk for MG patients.
Yep.
Is the Inspire a local anesthetic or is it a general anesthetic?
It's a general anesthetic, so it is a surgical risk you have to think about. And the remedy, the other one, is more local. That one's just sedation. It's not full general anesthesia, but the Inspire is general anesthesia, but it's a short procedure. It's not a long procedure, but I do understand that sometimes anesthesia can cause issues. So it's just, letting the anesthesiologist know about if issues you've had in the past or what anesthetics have not worked for you can be helpful with minimizing those risks. But, people with myasthenia, like anyone else, are going to have surgeries at some point, probably in their life. So it's something you have to deal with from time to time. So.
Yes, Chris, I have a follow-up to the answer you gave about getting about changing therapists. So the question is, can you explain why it isn't easier to change a therapist?
Why it isn't easier to change the therapist? You mean,
Yeah.
like, are they saying like the DME? I'm assuming they're asking.
Yeah, respiratory therapist from
Oh.
the DME company.
Oh yeah, I mean, most DMEs have a couple respiratory therapists. It depends on how small they are. If it's a small office, they may only have one respiratory therapist. But most, like Benson's has several locations, especially on the east side in Lansing. So you could try a different office, and they may have a different respiratory therapist to work with. As long as you stay with the same company, you should be fine. Waiting to get that waiting until you pay off the machine. But if you've paid off the machine, you can go wherever you want. You can try a different DME company. You can go to your sleep doctor and ask them if they have respiratory therapists that can work with you. So.
All right. So here's another, this more MG specific. 3 years ago, I was placed on a BiPAP after poor FVC testing.
Yep.
It is working well. My primary care insists she knows better and I should have a sleep study and be on a BiPAP. She believes a CPAP is superior. Any idea how I can get my primary care to accept my doctors and my opinion?
I assume there was a typo there, and they were saying that the primary care wants them on a CPAP and not a BiPAP. Is
All right,
that
look,
what?
so let me read that. Maybe I read it wrong. My primary, so the primary doctor insists I should have a sleep study and be on the BiPAP.
Yeah. So CPAPs are generally, especially in myasthenia, I prefer BiPAPs because there can be respiratory muscle weakness that's paradoxical, that comes and goes. So even if you have a spot on a sleep, even if you have a sleep study that shows CPAP is working great, if you're in an exacerbation, a BiPAP is going to be better. So if you do fluctuate with your respiratory weakness, it's better to have a BiPAP on board so that we can adjust that if you are getting weak with your breathing at times. Because the CPAP won't help support your breathing at all when you are in an exacerbation or when you are having trouble breathing. So that may keep you, off a ventilator or from going into the hospital if you get worsening. So I prefer my patients to have BiPAPs, and I usually, oh yeah, and somebody just asked, can you explain the difference between a CPAP and a BiPAP? Yeah, so a CPAP is just a single pressure. So it just uses one pressure to open the airway. A BiPAP uses two different pressures, where you have a higher pressure when you breathe in and a lower when you breathe out. And there's a difference in that air pressure with the breathing. So it actually gives you that difference in the pressure is called pressure support. So it actually gives you support in your breathing. So it expands the lungs more. It helps to relieve that relieve your body from your own muscles opening the lungs, and it kind of expands it with you. So that's why it can support your breathing better than a CPAP can.
And
Any
I
other
don't know.
questions? You're welcome to unmute
You
yourself.
can you can have, you can give the primary care my name if she wants to call me. I'd be happy to talk to her about it. I'm always open to talking to other physicians if they with this, but I tend to put any of my myasthenia patients on it. And sometimes myasthenia patients don't come to me at all because the neuromuscular clinic will just put them on a BiPAP without having them come to the sleep center. So that happens too. And I'm okay with that if patients do well with that, but sometimes we need to get a sleep study to see what's best for their comfort and treatment.
Right, because there could be more than one source, is your point, right? You just want to make sure we don't blame it all on myasthenia or vice versa.
Right. But usually in the BiPAPs, it'll treat some of the sleep apnea too. But if things are still not working after going on a BiPAP, you'd probably need a sleep study. And they're leaning more towards getting sleep studies now with insurances before you get a BiPAP just put on. So
I also think that the aspect of central sleep apnea, which is, needs to be assessed whether that is now occurring because of weakness and things like that. So, can you explain the difference between sleep apnea, which many people have from snoring or things like that, and central sleep apnea?
yeah, so I touched that on a little bit in the beginning of the presentation. So the obstructive sleep apnea is what I had showed where the throat is getting closed off here. So the throat's getting blocked off. So there's a narrowing in the airway. The air is not getting through, and we're trying to do things to open the airway up so that it gets unblocked. With central sleep apnea, the airway is open. So there's still free flowing air, but the brain actually tells the body to stop breathing. And that can be for a variety of reasons. There can be issues where you're not getting that signal into the diaphragm because of maybe a past injury to the brain, so like a stroke or traumatic brain injury. But also, some people just have trouble regulating their breathing when they sleep naturally. It's just that they have their system and regulation, the CO2 levels in the blood is off a little bit and they just stop breathing. It can also be worse from opioids. So opioid medications can lead to central sleep apnea. So if you get on those for pain or whatnot, that can exacerbate it. Or high altitude can do it too. Some medications can lead to it. So there's a variety of different causes for central apnea, and sometimes you can get central sleep apnea from CPAP. So we try to treat obstructive sleep apnea with CPAP, and then it can induce central sleep apnea in some patients. And then we have to use more advanced machines to control both of them. So there's, but the machines we use for central apnea will help stimulate your breathing with kind of a burst of air while you're using it, to help you breathe better. So,
Dr. Morgan, we have, oh, is it okay, Susan, if I ask this last one?
Yes, yep.
Okay, okay, do the implantable devices tunnel in vein? Tunnel in vein. Can you see that question?
yeah, yes. So the Remedy does. The Inspire does not. The Inspire just goes under the skin up to the hypoglossal nerve. The Remedy device, which is used for central sleep apnea, it's done by a cardiologist, and they go through the vein, and they go down a certain vein that sits right next to where the phrenic nerve is. So yes, for that device they do, but that device is, much less used because central sleep apnea is not as nearly as common as obstructive sleep apnea. So,
okay.
So having a good sleep center do a sleep test in order to figure out the type of apnea is really important.
Yeah, for sure.
Okay, I'm going to turn this back to Susan then. Thank you so much, Dr. Morgan. Great interest.
Yeah, thanks.
There's one last question.
Sure.
A writer writes, actually 2 last questions. She has had 5 separate lumpectomies due to breast cancer. Do lumpectomies affect ability to breathe?
They really shouldn't, because lumpectomies are usually, unless it's like a complete mastectomy, sometimes they take some of the the pec muscle there. But even the pec muscle shouldn't affect breathing too much. It's usually like the like the muscles in between your ribs, or the muscles in your neck. So unless the cancer got up into the neck muscles or the ribs, it shouldn't be affecting your breathing muscles. If it's just breast tissue, it shouldn't affect it.
Okay. One last question. Could it cause SVC syndrome?
It's referring
Oh,
to
yeah. So that,
implantable devices.
yeah, I mean, anytime you're messing around in the veins, I assume you can cause blood clots, because what I know from SVC is like just more blood clots that happen in the veins. I mean, that's an inherent risk to any time you go into a vein and you're putting a foreign object in there, you can get blood clots. But I don't know specifically about how common is that with this particular procedure or other procedures. That's not something I'm well read on. So
Thank you, Chris. Excellent presentation. Really appreciate you being available today, and also, speaking so well towards some of the things that we really have heard in some of the support groups and things like that. And I really appreciate you kind of going through it. Again, this is recorded, so that will be available on our website if you want to forward a link to your doctor, or also share that with anybody else who who might also be affected.
thanks for inviting me.
You're welcome.